Thank you very much. Lovely to be with you all again today, and how things have changed over the last few months. So I'm going to go through the big picture. So let's look at the worldwide situation first of all. So daily cases from the beginning back in February, March last year, the first peak, then the second peak, but globally now the number of cases is dropping quite dramatically in just about every country around the world. And the daily deaths is following that by a couple of weeks as well. But the daily death rate now is averaging below 10K per day. Considering it was up to 16 or 17K, that's a dramatic fall. If we look at the numbers, sometime today, we're going to pass the 2.5 million deaths mark. And I've got the pictures on the right there of the deaths in both the UK and the US, and you can see in both of these that there's the first wave, then followed by a smaller second wave, and then the much bigger third wave, which we're now well on the down curve of. So deaths now in the UK down in the low hundreds, even on weekdays. So dramatic changes we've seen. How bad is this? Well, let's think of all the worst plagues in world history, and there are 7 that have been worse in terms of total deaths. So we're now passing the Mexico epidemic of the 1600s, and we're into the top 8 now with 2.5 million deaths altogether. So significant. If we look at the worst countries by total deaths, then you'll see that the UK is at number 5 with 121,000, probably higher than that if we go by death certificate notifications of COVID. So only the US, Brazil, Mexico, and India are worse than us. A much better measure is the deaths per million population, and the UK there is 6th, so about the same level with 1,781 deaths per million population. In the top 20 countries by this measure, you can see only 3 of them, the US, Mexico, and Peru, are not in Europe. All of the other countries are in Europe if we look at deaths per million population. If we make the comparison between Britain and Ireland nations, so I'm from New Zealand, so you forgive me putting that one there, but 5 million people, 26 deaths total, 5 deaths per million. Taiwan, even better, 0.4 deaths per million people, population, almost half that of, or a third that of the UK. Hong Kong, similar number, total deaths 197, and deaths per million 26. Singapore, the same level as New Zealand, 5 deaths per million population. Japan, you'd say would be one of the worst big island nations. It has a population twice that of the UK, 7,500 deaths and 60 deaths per million population. So 12 times as bad as New Zealand and 120 times as bad as Taiwan. But look at the UK there, 68 million population, 121,000 deaths, and the deaths per million population is 1,781. And beware of making many of the comparisons are made within Europe and the US states, but we've got to look at this at a global level. Now, this is my uncle's 90th birthday in New Zealand just a few weeks ago. He's there in the front, 90-year-old, and my 86-year-old mother is there. There are 8 doctors in that extended family. You can see there's very little in the way of social distancing going on because New Zealand is essentially free of COVID, and all the generations can mix without any concern at all. And of course, it makes it better because it's summer there at the moment. So why has the UK done so badly? These are the reasons. We failed to close our borders. We're at least a month late back in February, March last year. That meant a huge load of virus. We let it escape into care homes initially by sending people home from hospitals infected. Many elderly people died. We locked down and introduced mitigatory measures too late. We lifted restrictions too early in the summer, and we never managed and still haven't managed to make track and trace work. And these are the reasons why the UK has one of the worst fatality rates in the world, and we have to own that. So this is the UK daily cases. You see artificially low at the beginning of last year because we weren't measuring them. but with the second and third waves there from October on to February. And the daily deaths, which are a much better measure of severity, and even though we have better treatments, we're seeing more deaths per day in the more recent times. So why do the other island nations do so well? Well, just you turn all those answers around. They closed their borders very early. They didn't let the virus into care homes. They implemented mitigatory measures. They locked down early. They implemented effective track and trace. My sister-in-law, my brother's wife, is a GP in Auckland and responsible for a track and trace team. And it's just extraordinary the way they do it. But of course, the problem in Europe is that the cases were so high that track and trace was never going to work because it would overwhelm the facilities. You need very small numbers in order to do it effectively. So we all know the mitigatory measures, and they make a phenomenal distance to or difference to the rise in numbers of the virus short of lockdown. In fact, in tier 3 and tier 4 we see work very effectively until the new variant came along. But the big game changer, and this is where Britain has done phenomenally well, is a world leader from worst in the class to best almost, is in vaccine rollout. And we're seeing a spectacular impact on serious illness because of vaccinations. And as you know, we've got 3 vaccines approved. We've got 2 others, Novavax and Janssen, which are pending and should be available fairly soon. And these all have very good effectiveness. And the other thing Britain did phenomenally well was to order lots of vaccine doses long before they became even approved. So this is where we've left the rest of Europe standing still. Look at those numbers: Oxford, AstraZeneca, Valneva, and of course those numbers are many more than the British population, which of course raises questions about what we do with our excess later on. We'll come back to that. So working through the groups, we've now been through the first 7 groups in the top orange shaded area. We're now into, we've been through most of the 65 to 69s. We're into that big group of 7.3 million 16 to 64-year-olds with underlying health conditions. So my wife had her vaccination just last week. Under that, I'm still waiting for the 60 to 64-year-old group, but it's going to happen fairly quickly, we'd expect. And the plan is by 31st of July, expanded to all adults. And phenomenal organisation, hats off to Britain in terms of setting up the vaccination centres. And I think that the thing that we did really well was to delegate it to the NHS and GPs in particular. I benefit from living in St Albans with one of the best rollout systems. And so if we look at the worldwide picture, only Israel and the United Arab Emirates are doing better than us in terms of doses per 100 people in countries. And you can see the rest of Europe, even the best countries, are a long, long way behind Britain. And the early data is showing that vaccinations are making a huge difference. So this is the Israel data leading the world, and you can see how the over 60s admissions to hospital is dropping dramatically from early January to early February, still going down. Of course, they're the group who've been vaccinated. And Israel is easing the restrictions after this. So already shops, libraries, museums can open, still some social distancing, but the return to normal life is proceeding. So these are the big numbers you see on the BBC. The notable things, we've noted 121,000 deaths. It's probably close to 140,000 if we take death certificate notifications. Cases, you can forget that because of the early errors, but the number of people in hospital is now halved from the peak of 30,000. Now that still means there's a huge number of people occupying hospital beds with COVID and stopping other things happening, but we're tracking on with the vaccines now into the 18 million mark who've been vaccinated. And then the roadmap, John's already given you the implications for churches. The thing to grasp here is that there are 4 stages, all of them leading on to the 21st of June, when we're hopefully going to be effectively back to normal. And so on the 8th of March, schools open, meeting one person outside for coffee, care home residents can have a visitor. No earlier than the 12th of April, all shops open, restaurants and pubs can serve outdoors, gyms, spas and hairdressers can reopen for family groups, and you can have a UK domestic holiday as well just after Easter, weddings up to 15. By no earlier than the 17th of May, 30 people can meet outdoors and 6 people indoors. Pubs and restaurants can serve indoors, 30 people at weddings, museums, theatres and cinemas can open, and international leisure travel can start in mid-May. And then at the last point, stage 4, 21st of June, all legal limits on social contact removed, no legal limits on weddings, funerals and other life events. And finally, the nightclubs reopen. So it's still some way to go, but when we look at the progress over the last 12 months compared to the last or the next 3 months, it's going to be absolutely phenomenal progress in comparison. And those dates are of course not certain. They depend on these 3 things or 4 things. Vaccination program goes to plan. Well, there's no indication that it's not going to in terms of supply chains and personnel available. Vaccines are reducing deaths and hospital admissions. Well, that's already happening. Infection rates don't cause a surge. I think the government's erring on the side of caution and that's unlikely to happen. Perhaps the unknown is about new variants, whether they're going to fundamentally change the risk. At the moment, the new variants are not more virulent, but just more easily transmissible. So there are good reasons to be optimistic looking forward. New variants. There are 3 that we know about. The UK variant, the South African and the Brazilian one. It's early days for these in terms of their spread. In other words, we think most countries in the world haven't had large numbers of these yet. But we've seen the most dramatic effects were in Manaus in Brazil, in the Amazonas province, where there was such a surge of new cases because of the new variant and more rapid spread that they ran out of oxygen. You've had frightening scenes like this, and the doctors I know through ICMDA who were living there were just absolutely overwhelmed because there were no spaces in the hospitals for people. Variants and vaccines, we know that the bottom line is that the vaccines are less effective against the variants, but not markedly so. And we just have to watch this. We know that they're not going to be more virulent, and if not more virulent forms arise, then we should be, if we press on with vaccinations worldwide, be doing well. It's one of the tragic pictures from Manaus. This came out a couple of days ago that in Zimbabwe now, the South African variant is now the dominant strain. So you remember, just as the UK variant became the dominant strain in November, December this year. So that's has repercussions. And there's evidence now that there might be substantial underreporting of deaths in Africa. This was a paper in the British Medical Journal just this week, where they were saying that 1/5 of all deaths were linked to COVID on post-mortem examination, and that the average age of people dying were under 60 years, and those particularly with comorbidities including TB, hypertension, alcohol misuse, HIV/AIDS, and diabetes. So we know in India that the number of cases, the generally accepted figure is that the number of deaths is 5 times higher than is currently reported. Treatments are improving all the time. The real breakthrough, of course, was dexamethasone and prone positioning and respiratory support devices, but there are more and more showing tentative or mixed evidence. And the result of that is that the fatality rate's fallen quite dramatically, down 30% since last April 2020 because of the combination of treatments. So we expect that's going to continue with new developments, but the real game changer, of course, is vaccines. Now, all the way through, we've been on this journey between Scylla and Charybdis. On the one hand, the Scylla of the virus itself and its effects on morbidity and mortality, and on the other hand, the Charybdis, the whirlpool of the sequelae for us economically, socially, in terms of education, healthcare, and so on. And this was the Lancet's View, leading medical journal. The pandemic is dismantling the foundations for protecting and advancing health. Global health has entered a period of rapid reversal. De-development is the new norm. And I don't think this is overstated from what we're hearing from lower and middle income countries. So last time, you might remember, we looked at this in a bit more detail. People being pushed into poverty, worsening mental health, family breakdown, and crucial medicine inaccessible for the non-communicable diseases like cancer and hypertension, heart disease, and also for chronic diseases like mental health. So we have these four curves. The first curve of the morbidity and mortality from COVID itself. The second wave, which is the impact of resource restriction on urgent non-COVID conditions. The third wave on chronic conditions like hypertension and diabetes. And then this red curve is the psychological trauma curve, the US data that we looked at last time, showing the sort of things that you'll be seeing in churches as well, particularly among young people. And of course, now there's a big push, given the inequality of rollout across different countries, for the UK and other Western countries to send vaccines to poorer nations that they don't need. So a call coming from the top of the UN itself, the WHO chief, lambasting vaccine profits and demanding that the elderly and the vulnerable go first. And I think this is one of the biggest challenges facing the church in terms of advocacy. Our own Prime Minister has, in a way, led the way in pushing for G7 countries to increase support for the COVAX scheme, which is a scheme designed to provide effectively billions of doses for lower and middle income countries, donated from richer countries. And let's remember that the effects, if we think the effects on the economy and life in general here, on health and education here are bad, they are much worse in developing countries. The economic effects we know too well. So this is the Office of Budget Responsibility from today. So looking at the rising internal and government debt, and looking at debt as a percentage of GDP over time. So this is the Second World War here, and we're now at a level that we haven't seen since the 1960s. This is government borrowing. So from 1993 through to the present day, and of course this huge spike in 2020, 2021, and then debt as a ratio of GDP is higher than it's been for many, many years. And yet not everyone is getting poorer, and governments are increasingly in debt, but the area that's doing particularly well is big tech. And of course, of the biggest 10 companies in the world now, almost all of them are IT companies. So the FANG, the Facebook, Alphabet, Amazon, Netflix, Google, and so on. And the richest man in the world now is Elon Musk, who's come from back in about 30th place over a year, the founder of Tesla. And he's just today, I think it has, slipped back behind Jeff Bezos, the Amazon boss, because he spent £1.5 billion on Bitcoin, $1.5 billion on Bitcoin. And so the share price dropped as a result for Tesla. But this is the NASDAQ index, which is the index for big tech in the in the US. And you can see how incredibly well they've done. So generally, we've seen the rich get richer and the poor get poorer through this worldwide. Misinformation. This slide comes from the monthly COVID bulletin that I put out through ICMDA. And people have been talking about the pandemic of misinformation being just as bad as the COVID pandemic itself. And last time we looked at some of the what I've called the Christian memes that are circulating amongst people. Issues around safety and ethics of vaccines. We can perhaps come back to that in question time, but there have been questions raised about the link between past abortion and the production of some of the vaccines which have used fetal cells in their development, but of course contain no fetal material whatsoever. And we could perhaps come back to that. But just as an example of the misinformation, this is an email I received 3 days ago from, you can see, from Majid Khatmi, who I know reasonably well, who was the director of the Islamic Medical Association in the UK. And he sent out this email with 20 supposed myths listed, all very impressively and professionally done with scientific references and so on. And I was wondering, well, where's all this coming from? And it's all coming from one of the groups that set up recently. This one is the UK Medical Freedom Alliance. You can see very professional, very impressive. This is the Alliance team. You might begin to ask questions when you see that there are 3 GPs here, one of who's retired. And then there's a couple of integrative doctors and an osteopath on the panel as well. So my message here is, don't be fooled by very professional looking presentations by people that are coming out. If you go to their Twitter site, you will see that they have a small number of followers, just 2,500 altogether, but they're followed by very significant people, and particularly journalists who will get their stuff into the mainstream through blogs like The Conservative Women, which Kathy Gingell, who I also know, writes for. I think one of the best sites on misinformation is this one, Antivirus, the COVID-19 FAQ, which is written by a number of doctors and scientists. And what they do is they take what they call the common COVID skeptic claims, and each one of them, you can click on these and see a rebuttal, the scientific references and the arguments in red text given by COVID skeptics. From ICMDA's point of view, we have a COVID page which has just been updated in the last few days or so, that you can find at icmda.net, and you'll see links there to general information, health advice, stuff about vaccines, talks and videos, webinars from our webinar series, and so on, and the last 12 editions of the ICMDA COVID Bulletin, which you can see here. I put this out once every month. The last one came out last week, and I try to keep it less than 1,000 words. It's usually 800 to 1,000, so just 8 items with 100 or so words each, with links to the latest developments. And then we run a COVID, or at least we run a webinar every week on a Thursday at 2 p.m. You can come free to that. It's broadcast all around the world. And a lot of these have been on a COVID theme. And we try to get, we have all Christian speakers and experts. So most recently, at the end of January, we had Professor Annalise Wilder-Smith, who was a professor in virology and advisor to the World Health Organization, and you can hear her speaking about vaccine inequality there. She gives a talk for about 3/4 of an hour, and then a Q&A for half an hour, and that's available up on our YouTube channel as well.